44 du Comité permanent de la condition féminine, conformément à l'article 108.2 et à la motion adoptée par le Comité le 27 janvier 2026. Le Comité entreprend l'étude des répercussions de la ménopause et de la périménopause sur le marché du travail. La réunion d'aujourd'hui se déroule sous forme hybride. Et j'ai quelques commentaires à faire pour la gouverne des participants. Veuillez attendre que je vous donne la parole. Si vous participez par Zoom, cliquez sur l'icône du microphone pour activer votre micro et vous mettre en sourdine lorsque vous ne parlez pas. Vous avez le choix entre français, anglais ou parquet. Veuillez utiliser la fonction lever la main si vous souhaitez intervenir.
Il n'y a pas d'interprétation, Madame la Présidente.
Okay, does it function now?
Oui.
Adrienne? It's okay? Very good. All right, sorry about that. And so I'd like to recommend to the witnesses that committee members are going to ask questions in both official languages, and so you can pick your interpretation, address all comments through the chair. And so now we're going to welcome our witnesses. We have Penina Alon-Schenker, Associate Professor from Toronto Metropolitan University. And we have Roberta Heel, Full Professor, Laurentian University. And from the Women's Health Collection of Canada, we have Amy Flood, Executive Director. So welcome, and we'll begin with opening statements. Ms. Alon-Schenker, the floor is yours for 5 minutes. Thank you.
Thank you, Madam Chair, and thank you, the members of the committee, for the opportunity to speak today. My name is Penina Alon-Schenker, and I'm an associate professor at Toronto Metropolitan University. I have studied age discrimination in the workplace for more than a decade. My most recent work, co-authored with Professor Asher Alcoby, addresses the gaps in legal protections for menopausal workers. This study was shared with the committee prior to this meeting. Although available data suggests that menopause affects a large segment of Canadian workers, employment and labor laws remain largely silent on menopause. In the absence of explicit legal protections, employer-initiated menopause policies are rare, and menopausal workers encounter barriers to meaningful participation in the labor market. Indeed, women's labor force participation declines significantly as they age, and this decline may be caused by a variety of factors, but there is some evidence to suggest that these include menopause-related challenges. We found that there are very few litigated cases in Canada on menopause at work. The cases we discuss confirm previous findings that workers often lack the knowledge of what they experience and what they need, and when they do, the absence of inclusive workplace policies together with persistent stigma prevent them from seeking or receiving appropriate accommodation. Menopause is often perceived as a personal problem rather than a human rights issue. Further, discrimination claims are reactive in nature, and they often mark a breakdown of the employment relationship in ways that are difficult to restore. Raising awareness through education of workers, employers, health professionals, and adjudicators is critical, not only for ensuring that such claims are brought forward and that they succeed, but also from preventing discriminatory practices in the first place. The breadth of case law in this area is unsurprising. Menopause and its effects on women's health are still understudied. There is a substantial knowledge gap, lack of awareness, and stigma surrounding menopause. Survey data show that unmanaged symptoms and the challenges experienced by menopausal workers contribute to reduced working hours, job loss, and premature exit from the workplace. The impact on employers and the economy is also significant, including lost productivity and difficulty retaining top talent. Other countries, such as the UK and Australia, have recognized the economic and social significance of these challenges and conducted comprehensive parliamentary studies informed by extensive consultation with stakeholders. We are pleased to see that the Standing Committee on the Status of Women has now embarked upon a similar initiative. The UK and the Australian experiences make clear that there is no one solution that fits all workers and sectors, and that the way forward requires the introduction of integrated and coordinated measures to support menopausal workers. Our study underscores the importance of exploring a multifaceted regulatory approach that would increase awareness, support employers' interest in retaining and attracting talent, effectively address stigma and silence, and protect workers' choice and autonomy at work. Indeed, Canada would benefit from a comprehensive national strategy that will promote the introduction of proactive regulatory measures and be accompanied by awareness-raising and education campaigns to break the silence surrounding menopause at work. Proactive regulatory measures that we recommend in particular include the introduction of workplace policies, menopause training, paid leave of absence, and a stronger right to request flexible work arrangements. Further, we argue that there is an important expressive value in explicitly recognizing menopause under human rights legislation at the intersection of age, sex, and disability. This could help raise awareness, facilitate the development of menopause-related workplace policies, promote a proactive duty to remove barriers, and create a clearer pathway to accommodation requests and more inclusive workplaces. Finally, our review of other jurisdictions observed a normative shift towards a universal right to workplace accommodation, focusing on the actual need for accommodation, regardless of the individual physical or mental condition, would ensure the effective removal of social and environmental barriers that restrict meaningful participation in society of all Canadians. Indeed, research shows that women wish to remain active in the labor market and are often able to do so with simple and inexpensive support and adjustments. This approach would also help address concern.
If you could wrap up your comments, Ms. Thank you.
Can I finish the last sentence? Or yeah?
Absolutely.
Yeah. So this approach would also help address the concern that designing menopause-specific measures may inadvertently reinforce stigma and prejudice. Thank you so much for your consideration of these matters.
Thank you so much. I'm sorry, but we were very tight for time with these votes today. So now, Dr. Heal, the floor is yours for 5 minutes. Thanks.
Thank you very much for inviting me here today. I have been a nurse practitioner for close to 27 years, and I'm a full professor at Laurentian University. I continue to practice as a nurse practitioner and opened the virtual menopause clinic 4 years ago. And I've learned that women in midlife undergo profound physiologic changes that result in a whole host of symptoms. Every woman is different, and the symptoms they experience and the severity of them can vary considerably, but perimenopause and menopause symptoms impact all areas of a woman's life, most definitely work. Many of my patients have told me the impacts of these symptoms, and comments like, "If you hadn't treated me, I would have had to quit work," prompted me to develop a pan-Canadian survey to gather data about this experience. The survey is still live, but the preliminary findings are concerning. 47% of the survey participants reported that they've missed work because of symptoms. 45% have reduced work hours. 43% have taken sick time or vacation time to manage their menopause symptoms, and 31% are considering leaving their work. Overall, the findings are not surprising. Menopause symptoms significantly impact work, and in addition, most workplaces lack policy, awareness, or accommodations. The findings mimic what we know. Up to 10% of women leave the workforce because of menopause symptoms, and these are their peak earning years. So these are going to have an impact on them financially for the rest of their lives. The cost to women is enormous. The cost to organizations, employers is huge, with an estimated $237 million annually lost to menopause care and symptoms, and an estimated cost to organizations of up to $50,000 to replace senior employees. We can't talk about menopause at work without talking about the barriers to receiving care in menopause. The lack of accessibility to knowledgeable menopause care providers is very common. Accessibility to affordable treatment is a barrier, and more women are turning to private pay. Hopefully, when all provinces have direct remuneration for NPs, this will solve part of the problem. If a woman doesn't have drug benefits or coverage for things like counseling, they have to pay out of pocket. And that menopause treatment is prohibitive. It's very expensive. There are other related issues. The ongoing black box warnings on vaginal estrogen products have been removed by the FDA in the US, but remain in Canada. This contributes to the confusion and the tsunami of information and misinformation that women experience about menopause care, as well as the hesitancy of some providers to providing with actual care. There are many strategies that could be considered at the federal level. And first, to continue to prioritize menopause hormone therapy in the National Pharmacare Plan, and to trigger reviews of products so that the approvals are aligned with evidence. Next, to continue to ensure that all jurisdictions develop direct remuneration for MPs to help reduce costs to women, but also to consider the establishment of regional centers of excellence, and I know there are a few across the country right now, to train healthcare providers and create public education programs, the goal being to move menopause care back into primary health care. Another is to consider menopause as an issue of equity. Again, the UK has legislation to eliminate discrimination against women when they need to adjust their work related to symptoms. To advocate for workplace environment standards, such as policy frameworks, which emphasize things like physical workspace adjustments, ventilation, or even just access to appropriate washroom facilities. Review a national health workplace strategy, such as in England and Scotland, which supports menopausal transition to in the workplace, strategies such as employers signing pledges to implement formal menopause policies. And finally, to consider funding and developing a national clinical guideline for the management of women in the menopause transition that truly reflects current evidence and practice. Menopause at work impacts millions of women. Providing care to women in the menopause transition has shown me how much needs to be done to ensure optimal workplace environments during this critical stage. And I look forward to this report from this committee. Thank you.
Thank you so much. Now, Ms. Flood, you have the floor for 5 minutes.
Thank you very much. Good afternoon, everyone. My name is Amy Flood. I'm the Executive Director of the Women's Health Collective Canada. Women's Health Collective Canada is a national alliance of 5 of the leading women's health and women's research institutes working together to advance women's health through research, advocacy, education, and coordination of national action. Thank you for the opportunity to represent women's health research and the topic of menopause and its importance to the workplace and productivity. Bringing people together across health, research, innovation, and policy is exactly how progress happens in women's health and why conversations like this matter. Women's health remains underfunded, under-researched, and too often misunderstood. In Canada, we are 51% of the population, 47% of the workforce, and are forecasted to own nearly 50% of our country's wealth by 2030. And yet only 7% of health research funding is dedicated specifically to women's health. For decades, clinical trials and research was largely designed around male bodies with male norms. While policies have evolved to require the inclusion of women, gaps in evidence and care persist today. This results in a system that has never been fully designed for women, and we see the consequences. Women are waiting years for diagnosis, they are misdiagnosed, or they are living with untreated conditions that affect not only their health, but their ability to fully participate in the workforce and in life in general. These are not isolated issues. They are systemic outcomes of decades of underinvestment. They show up every day. Women account for the most of the adverse drug reactions linked to how medications have historically not been tested on women. Nearly half of adolescent girls are missing school or activities due to menstrual health challenges, and 40% of mothers are considering leaving the workforce during the postpartum period. At the same time, women are living longer than men, but spending 24% of that time in less health. And the majority of that 24% of time in less health is during the critical working years. Hormones and the hormonal transition through perimenopause and menopause is one of the largest drivers of women's health equity gap in Canada. Approximately 10 million women in Canada are over the age of 40, encompassing those in perimenopause, menopause, and postmenopause. Perimenopause symptoms are showing up earlier in women today. Healthcare providers report seeing women in their late 30s and 40s experiencing perimenopausal symptoms such as irregular periods, hot flashes, brain fog, and mood swings. An estimated 1 in 10 women step away from the workforce due to unmanaged menopause symptoms. 40% of women still experience menopause symptoms in their 60s. It is estimated that menopause symptoms cost the Canadian economy approximately $3.5 billion annually. Employers incur around $237 million each year due to lost productivity. Women face $3.3 billion in lost income stemming from reduced work hours, decreased pay, or exiting the workforce entirely. Menopause-related symptoms lead to approximately 540,000 lost work days a year in Canada. 32% of working women reported that their menopause symptoms negatively affected their job performance. Factors contributing to these trends were increased stress levels, environmental toxins and endocrine disruptors, diet and lifestyle changes, hormone treatments, etc. Menopause research in Canada is critically needed. Governments need strong data to create health campaigns and funding programs for menopause care. Canada is behind countries like the UK, which is making menopause a public health priority. We lack a Canadian-specific data. We lack knowledge in healthcare. There's limited research on the long-term effects of menopause hormone therapy and treatments. There is lack of mental health and menopause support in the workforce, and we lack knowledge in workplace and economy. A 2024 report by the Women's Health Research Institute found a third of women's work performance was affected by their symptoms, yet their workplaces lacked the policies to support them. We're asking that employers consider these top 6 things to help women through their menopause transition. Normalize the workplace conversation. Create a culture where menopause can be discussed openly without stigma. Education and awareness, and help employees feel supported and reduced the barriers to seeking help. Train managers, equip your leaders with the knowledge and confidence to understand menopause symptoms, have supportive conversations, and provide appropriate accommodations when needed. Offer flexibility, flexible work arrangements, including hybrid work-adjusted schedules and flexibility for medical appointments, can help manage symptoms while remaining productive and engaged. Enhance benefits and support.
If you could wrap up your comments. Thank you.
The cost of support is far less significant than the cost of short-term and long-term disability. And support research and evidence-based in menopause solutions.
Thank you very much. Sorry about that. We're pinched for time. So we're going to start into our first round of questions with Madame Vienne, 6 minutes.
Merci beaucoup, Madame la Présidente.
Thank you very much, Madam Chair. Look, I'm so happy to have these 3 women with us here today. I'm one of those who really worked hard. I didn't have to work too hard, given that colleagues around the table, I do believe, understood quickly, and indeed many of us are in perimenopause or actually have entered menopause, and thus have experienced some problems ourselves, a number of symptoms. And when I myself started asking what this was about, I realized that among those around me, not many, and not even many doctors were able to answer my questions. I've also seen many people experience a good deal of anxiety about what they experienced. Why? Because they didn't talk about it. We don't talk about this. And the more we remain silent, the more women will be sidelined. They will go through this alone, and the workforce won't change. My first questions go to Ms. Schenker. Ms. Schenker, you are working on the workplace, if I understand correctly. And, of course, I'm thinking of brain fog as one example. Women not being as quick in what they're able to do mentally. They have difficulty finding the right words. They feel guilty about this. Perhaps they're afraid that they will lose their job or will no longer be able to access a promotion. All 3 of you have said that there is a lack of information and lack of research about this. Let's begin with the micro-milieu, with the milieu right around you, your immediate environment. How can we change the workplace to ensure that colleagues one's boss, one's employer can be informed such that the woman could feel better understood and better supported. And of course, let's not forget the unions.
Absolutely. Thank you so much for the question. And I think it's really important. Myself, as others, have experienced that. And I'm thinking about the people that are not so lucky to have flexibility in their workplace, right? So whereas professionals and office workers have much more flexibility, there are people that need to be physically available at a certain time in a certain workplace without that. And only adjustments within the workplace can help. But the problem starts earlier, as Madame Chair identified, the knowledge gap, the idea that some workers are not even aware that what they're experiencing is menopause. There are some symptoms that are not much connected to one another, and you don't know how to put the finger that this is menopause. And once you realize it is menopause, is it a personal problem that affects my performance at work, or is it a human rights issue that deserves attention by unions, employers, in the sense of requesting accommodation? Because there's no discussion around that, because it's a taboo, because there's a lot of embarrassment and reluctance to share information in the workplace with human resources office, with employers, a lot of workers...
Sorry to interrupt you, Ms. Schenker, but how should we begin? Do we need legislation? Do we need regulations? Should the Minister of Labour, either at the provincial level or another level? I wasn't involved in the dynamic, you see, and that's perhaps why I'm not aware of how we should get going. But what do you think we should do first?
Thank you. So from the review that we have done in the study, there is nothing in the legislation that directly, explicitly mention menopause. You can make some connections within the existing protections, but there's nothing. So yes, I'm in favor of legislation. I think first and foremost, there has to be more research on the impacts of menopause on women in the workplace. And then there has to be a campaign increasing awareness in the general public, informing healthcare professionals, helping women understand what they're experiencing, and then also more awareness in the workplace. So, for example, in the UK, the recommendation of a committee, the parliamentary committee, was to appoint a menopause ambassador. The UK government adopted that recommendation and appointed a menopause employment champion that works with the stakeholders and recommend best practices and policies. I would even go further and mandate a menopause policy in the workplace, because when it comes through voluntary compliance, we don't see compliance. In other areas, we have bad experience with just trusting what employers will do.
Merci beaucoup, Madame Schenker.
Thank you very much, Ms. Schenker. I haven't much time. That's just the way committees work. Let me now turn to Ms. Flood. You mentioned hormones, and Ms. Heal as well. You did as well. MHR therapy, bioidentical hormones have been covered in the news in Quebec, which really led women to understand their symptoms a good deal better and to discuss them. So where are we at in Canada? This question is for all three of you, actually. What's the state of affairs in Canada with regard to hormone therapy and free access to it, because it's now free for women in Quebec?
I invite all of the witnesses that if you have comments to respond, please send them to the clerk, and the committee would be very happy to get them. Now we'll go to Ms. Nathan for 6 minutes.
Merci.
Thank you, Madam Chair, through you. So I'll ask my first question to Professor Alon Schenker. Did I say that correctly? I hope. Thank you. So, Professor, when I introduced this study, one of the things I heard repeatedly from women and advocates on this matter was that they often do not know whether they had any right to ask for support at work. So from a human rights and labor law perspective, do you believe that Canada's existing legal framework adequately protects workers experiencing menopause and premenopause? Or are women falling through gaps in our current accommodation system? Because I know women normally quietly reduce their hours, or they just stop working altogether, or make other excuses not to go to work. So I just wanted to ask your perspective on that.
Yes, thank you very much for the question. I think our existing laws inadequately protect women and do not encourage them to come forward with their requests. We have human rights legislation, and it does address prohibited grounds that could be relevant to menopause, including disability, age, and sex. But our system is very reactive in the sense that only once a person has been affected or adversely affected by discrimination, they may file a complaint, and the system is very individualized. So we are relying in terms of enforcement on an individual victim filing a complaint and arguing their case. When there's no policies in the workplace that address the issue of menopause, a process of requesting accommodation, women lack the knowledge, are reluctant, and even surveys suggest that they hide their symptoms. Hiding symptoms could be very dangerous in terms of health and safety, and can, as you mentioned, lead to premature exit from the workplace. So certainly I don't think we're doing enough. I think it's important to establish a pathway, explicit rules, explicit process, similar to what we have in the federal legislation with regards to requests for flexible work arrangement, right? There's a process, then you know that it exists and you know that you can request, and there's a process for the employer to either accept the request or reject the request with reasons. There can be a policy with regards to adjustments and support for menopause symptoms. Yes.
Thank you for that. Thank you for that response from you. So you're saying it's more so the policies, and we have to explicitly recognize them, and it's less about legislation and more about implementation of awareness among employers?
I think it's about legislation. And legislation can work in various ways. First, legislation can mandate a policy in the workplace. Or in the UK, for example, they mandate an action plan. So just like with equity legislation, you need an action plan. Show us how do you implement, how do you promote menopause, a inclusive environment? How do you review your current policies and amend them and remove barriers? So this could be done through legislation because you mandate those action plans, right? Or provide some model policies that workplaces then need to follow. Another way to legislate is to explicitly recognize menopause as a prohibited ground. Under sex, pregnancy is recognized explicitly under sex. Menopause or other reproductive health conditions are not, right? So it's not clear. Is it under age? Is it a disability? Some symptoms may apply, may be qualify as disability. We actually, in the case law, moved from the medical model of disability to the social model of disability, which doesn't look at the medical condition of the person, but what are the barriers in the workplace? So menopause works in that way. Even if menopause is not considered disability because it's a normal life stage, right? A common life stage that every middle-aged woman will go through. Still, a society or workplaces perceive that as an impairment to some extent. There's some stigma around that. There's prejudice. And when they don't provide adequate support and adjustments, these women are adversely affected, right? So legislation has, I think, a huge role here. Absolutely.
Thank you so much for that. So I'll move on to Ms. Healy here. And I just want to talk a little bit about the healthcare professionals and how well they're educated on this, and in school, when they go through their medical training, how much time is spent on explaining this to them? Because as we know, most of the physicians are male doctors. And I just wanted to know from your experience, how is this treated?
Well,
I'm very sorry you're at the end of your 6 minutes. I invite you, Ms. Healy, to respond to the clerk in writing. Madame LaRouche, vous avez la parole pour 6 minutes.
Ms. LaRouche, you have the floor for 6 minutes. Thank you very much, Madam Chair.
So could I have unanimous consent of the committee to continue until we get to the end of Madame LaRouche's questions? Yes? Oh. Mm-hmm.
And just to confirm, we will still end the meeting at 5:30.
That is correct.
Okay, yes.
All right, you may continue, Ms. Healy. Oh, sorry. Madame LaRouche.
Merci beaucoup, Madame la Présidente. Je remercie.
Thank you once again, Madam Chair. I also thank the witness for being with us, all three of them actually, Ms. Flood, Ms. Heal, and Ms. Alan Schenker for this important study. But I see this topic as being a very vast one. I think this is a study on what place our society reserves for aging women. It's more that than a matter of menopause. I think I used to work on mistreatment of elderly people, and what's the link? Well, we were talking there as well about age discrimination. So trying to render elderly women invisible in our society, be it by keeping them off screens, keeping them out of business, really across the board. This is something that I find to be of real concern. That said, I'll say that in Quebec we have had a wonderful champion, Véronique Cloutier, who made a wonderful set of shows on these topics. I've looked at the titles of the episodes she's put out, and it really brings to mind everything that you have already said in your opening statements. For example, perimenopause and menopause, you know, it's a kind of a lottery. You can feel it on such a day or not another day and so on. But why do we know so little about it? That was the second episode she put out. And then another personal issue. Is this a personal issue or is this a societal issue? So is this, you know, our problem or is this a problem that is a social one? And how shall we adapt our society to it? And then what are we to do? And that's about medication and our health system. Now, we're working at the federal level, so everything having to do with what's taught in medical schools, for example, is falls to the provinces, but research and medication and treatment, there's a link to the federal system. My first question, we could discuss adaptation and the workplace, but picking up on my colleague Ms. Vien's question, I'll ask you, where are we in research, in medication, in medications that have been accepted? She was mentioning bioidentical hormones, you know, all those sorts of hormones. So please, your response.
Mon Dieu, je sais, j'ai parlé aux trois témoins, puis c'est vrai que peut-être que...
I was addressing all three witnesses, but perhaps the treatments, perhaps Ms. Heal could begin.
For treatment for perimenopause and menopause is growing. We have a variety of very effective treatments, thankfully non-hormonal as well as hormonal. Some of the issues are accessibility. And we have to consider that some women will not want or will not be able to take these medications as well. There are other treatment options that are very effective. Cognitive behavioral therapy for vasomotor symptoms, for example, and yet all of those treatments, unless the patient has coverage, will be paying out of pocket, and they're all very expensive. Sleep is a huge issue, and hormones are not necessarily the treatment for that. So again, the treatments, cognitive behavioral therapy for insomnia can be extremely expensive. So I think you've hit on the nail on the head that it's so complex. There's so many facets to it. It's not just vasomotor symptoms. It's a whole host of things that sometimes are addressed with what we have and sometimes need other treatments.
Yes, and if I may add, I also feel that oftentimes, and I believe, Alon, you spoke to this, women are misdiagnosed. And so they are showing up with symptoms that are, as a result of perimenopause and menopause, but they're not being recognized as such. So they're being prescribed, SSNRIs and anti-anxiety and depression medication when in fact hormone therapy started earlier would have been the right first line of defense. So because there's not enough research in the actual symptoms and the linkage to perimenopause and menopause and that hormonal transition, the actual prescribing of treatment is inaccurate to begin with. Secondarily, I would say insurance companies are reluctant to carry treatments for menopause and perimenopause because of the cost associated, but the costs associated with short-term and long-term disability are actually much greater and a much larger risk. There is very much limited research studies on the long-term safety and effectiveness of hormone therapy. There's also a lot of research emerging showing that it's highly beneficial to other areas in long-term life of women, such as Alzheimer's and dementia. So we just do not know enough about all of the effectiveness of the treatments due to the efficacy gap. Things have not been treated on women or tested on women to begin with, and therefore misdiagnosed, misunderstood, misinformed. This is a root problem beginning with research and sex-disaggregated data.
Il me resterait 20 secondes si Madame Allen Schenker.
I have 20 seconds left. Does Ms. Allen Schenker have anything to add?
I'm not doing research on the healthcare system, so I don't want to comment on that, but, and I think I've commented enough for now.
No worries.
Thanks.
If you have any other comments, we can send them to the clerk. I understand there's unanimous consent to continue, and so we'll go to Ms. Goodridge for 5 minutes.
Thank you, Madam Chair, and thank you to all the witnesses for being here today. Ms. Flood, I really appreciate how you put down the details surrounding the women's research piece, and it's something that I have been very passionate about and have brought forward in a lot of different spaces because it is one of the big challenges. And so we're hearing about the workforce impacts, but perhaps if people had better understanding as to what they were going through, there wouldn't be the workforce impacts if it was actually being acknowledged and treated properly. And I think the only thing I can compare it to is being pregnant. In the moments before you realize you're pregnant, you think you're going crazy because you're terribly emotional. And once you realize that you're pregnant, you stop thinking you're crazy because you realize that it's just your emotions going a little bit wild because of the hormones, but you're not actually crazy, you're just pregnant. So this is kind of that circular space here. So my question to you is, how much research is being done and funded by the Government of Canada in the space of perimenopause and menopause?
I can't speak specifically to that. All I can say is, only 7% of research funding is being attributed to women specifically. And when you take oncology out of that, that is only 3%. I don't know the actual, dedicated research across perimenopause and menopause. And there is also obviously the transition from menstruation to pre-perimenopause to perimenopause, menopause, and beyond. And so, they're starting to see and identify this as actually a longer term journey than just perimenopause and middle age in its own right.
Is there any schools leading research when it comes to perimenopause and menopause from the health perspective in Canada?
I can speak specifically to, the research institutes within my collective. So, and they are associated with the universities in their areas. So the Women's Health Research Institute in BC, the Women's Health and Children's Research Institute in Alberta, Women's College Hospital Foundation, the MUHC in Montreal, and now the IWK in the Maritimes. They all have projects effects in menopause and how it's linked, specifically through the hormonal transition to other major areas of burden, such as cardiovascular disease, as well as, brain and mental health disorders and other chronic disorders that arise as a result of that hormonal transition. And then the affiliated universities are University of Alberta, University of Toronto, University of BC, University of McGill, and two of the universities out of the East Coast.
Thank you. Perhaps Ms. Heal, is there any diagnostic tools available to diagnose whether someone is in perimenopause, or what do they look like?
Oh, yeah, there definitely are. The Canadian Menopause Society has worked really diligently, and there are members of that to put together algorithms and treatment options for healthcare providers. And they often, one in particular I can think of, MQ6, has a link for women for information. So these are great resources, but it's sort of fledgling, and it's kind of not across the board about accessibility or usability for healthcare providers.
Okay, so I guess, and I'm not sure if this would be better placed to Ms. Flood or to you, Ms. Heal, but if a woman is thinking, maybe I am in perimenopause, what should their next step be? Like, what should they do?
I would suggest they see their healthcare provider, but I think, unfortunately, many healthcare providers don't have the knowledge base, and women are turned away. They don't understand the symptoms, and most often will go to social media. That's been my experience. So the amount of misinformation that women have is phenomenal, and then they seek help in other places.
Okay. Ms. Flood, do you have anything to add?
I mean, I would concur. I think the lack of research is contributing to the lack of knowledge. And also, there is no constant state of hormone. So you can't actually benchmark where a hormone is and a hormone level is to understand whether you're entering or exiting perimenopause or menopause. All you can do is correlate the level of symptomology and deduce based on age and your cycle where you are at and where you are predicted to go. But there is just very much a lack of training, knowledge, and education, and research is the number one port of call.
Very good. And now we'll go to Madame Menard for 5 minutes.
Merci, Madame la Présidente.
Thank you, Madam Chair. Ladies, your presence is so helpful. We are taking notes. Remain assured of that. You have a passionate group of people listening to you here. We are talking about perimenopause and menopause, but we do know that these are two different chapters in the lives of a woman. 8 and 9-year-old girls now do experience physical symptoms that then become, of course, the motherhood years, being pregnant, and then on to perimenopause and menopause. We have understood that not only are these changes misunderstood and poorly understood, but here at the federal level, we are trying to adopt best practices, respecting, of course, our areas of jurisdiction. Do you think that awareness-raising campaigns, and of course the idea would be to demystify, you've all said that we don't talk enough about menopause, and now should we expect employers to talk about it of their own free will? I think there are steps to be done before that. Could the help of the federal government, perhaps via the Department of Health, perhaps via other channels as well? This is an interesting approach. We will try to turn over every possible stone to find an answer through this study. What are we to do with the understanding, the recognition, and awareness? Because there are still so many stigmas. Not only that, but you also talk of brain fogs, of mood swings. Here we are women. I think we have all instantly recognized what you speak of and are thinking of the type of stigma that has been we have encountered based on these symptoms. I'd like to hear you about awareness raising, perhaps beginning with you, Ms. The interpreter did not figure out who she was. Heal, Ms. Heal. Thank you. I'm terribly sorry.
Sorry, they were just finishing. I think it's hugely important to have the Government of Canada promoting evidence-based information, and it can be done in a very collegial way, but in a way that people will accept and understand and trust. The women I see are feeling terrible, and they don't know what to believe. So if there's something that comes from a government campaign, public health campaign, then I think that would go a long way to help support knowledge not only for the women themselves, but for their families and the workplaces. I think there could be a several-pronged approach to do that.
Je serais curieuse d'entendre les autres témoins.
Very well. I'd be very curious to hear the other witnesses on this topic. If you would like to chime in, perhaps Ms. Flood, what could you add to this point of view, the concept of an awareness campaign to improve understanding of peri and menopause?
I think campaigns are necessary, and evidence-based campaigns, because there is a lot of misinformation out there for women, and they are turning to social media. And 9 times out of 10, that social media is ending in click here, buy this. And so they're not legitimate resources, and they're not being promoted for the right reasons. And I think a lot of the symptoms themselves are trivialized and misunderstood. You talk about it at a party and men think, well, what's so wrong with a hot flash? So you get hot. A hot flash is not a hot flash. It's a mini panic attack. Your heart is palpitating. You start to sweat, you start to lose focus, and you're trying to maintain a business presentation or coach your child's rugby game or what have you. And I think there needs to be evidence-based information for women, and there also needs to be, emotion-based information for women's allies. Your husbands, your brothers, your partners need to know what you're going through, and it needs to be rooted in real cause and real fact. And I think, I want to touch on what you just said about even the younger girls. There are far more issues, correlated to hormones like polycystic ovarian syndrome and endometriosis and fibroids and chronic pelvic pain, that if young girls knew more about their hormonal journey, they would be able to advocate for themselves, and they would get, diagnosed sooner, and larger issues around fertility and even magnifying your impact of perimenopause and menopause over your lifespan can be prevented. So this hormonal journey is so necessary and critical for more people to understand.
C'est cruel, je n'ai plus de temps, mais ce que j'entends, c'est que les...
Cruelly I'm out of time, but what I'm hearing from you is that women are conditioned to keep going even when they're in pain and just face down the challenges, and I think that we can help change that.
Madame LaRouche, 2 minutes et demie.
Merci.
Thank you very much, Madam Chair. And if I'm not mistaken, I'll be the one to bring an end to this very interesting hour with you, ladies. Thanks again. Once again, I am linking this topic to other topics that I have studied before. For example, I see this issue of menopause as linked to a study we carried out in the Standing Committee on Health, where I carried out a study about the health of women. And I see, and this is really picking up on prior questions, in which we could see the effects of menstruation on young women. They're having sometimes to interrupt their activities or cease certain activities. And then later there's the postpartum syndrome after women give birth. And these are topics that aren't necessarily brought up. I mean, a young lady won't necessarily tell people at school that she was in pain due to menstruation, thus she didn't turn up to class. Nor will they necessarily talk about postpartum depression after they give birth, nor will they talk about menopause. It's a taboo, and the effects are very real, and there are effects even on research about women's health, which clearly is insufficient to lead to better treatment and proper discussions when meeting one's healthcare provider, better discussions about women's health issues, which are taboo. So I'm seeing people nodding. Perhaps Ms. Alan Schenker, I see you nodding. What do we need to do? We have mentioned awareness raising. I would say, concretely speaking, healthcare research. What do we need?
So I think research and awareness come together. The research will provide you the information to inform all other initiatives, starting with the campaign and moving on to legislation and other regulatory measures. So research will provide you more of evidence-based information about where we're lacking and the economic and social costs of menopausal workers leaving the workforce prematurely. This is not an individual personal problem. It's a societal, economic issue. And this is why I think once...
That's the end of the time that we have today for the panel. But again, if you have comments that you'd like to send to the clerk, that would be great. I want to thank all of our witnesses for your excellent commentary today. And at this point, I'm going to suspend so we can change panels and vote. welcome our witnesses for the second panel. For the benefit of those that are new, if you want to check your interpretation, that you've got English, French, or the floor, whichever you want to hear the questions in, that would be good. And all questions will come through the chair. Now, let me just introduce our witnesses. We have, as an individual, Julie Drapeau, who's the Senior Vice President, Sales and Marketing of Purity Life Health Products, LP. We have Dr. Colleen Norris, the Carversan Chair in Women's Health Research from the Edmonton Women's Health Research. And we have Amy DeBow, the founder of Menovate. So we welcome all of you, and you each will have 5 minutes for your statements. Dr. Norris, you can begin for 5 minutes.
Thank you very much, Madam Chair and members of the committee, and thank you for the opportunity to speak today. My name is Dr. Colleen Norris. I'm a professor and associate dean of research at the Faculty of Nursing at the University of Alberta and the Kaversen Chair in Women's Health Research. I lead research focused on women's health, women's cardiovascular health, and the reproductive transition. I'm here today because Canada has an opportunity to correct a major gap in women's health care that has persisted for nearly 2 decades. 2 generations of women have been denied appropriate care during the reproductive transition due to the combined effect of the misinterpretation of the Women's Health Initiative and a long-standing failure to recognize the critical role that estrogen plays in women's lifelong health. As a result, the menopausal transition has been treated as an isolated reproductive event rather than in what it truly is, a whole-body biological transition. When estrogen declines, the effects extend far beyond hot flashes. Vascular function changes, bone loss accelerates, sleep becomes disrupted, metabolic risks increase, mood and cognition are affected. These changes influence not only quality of life, but long-term risk for cardiovascular disease, osteoporosis, diabetes, emotional and psychological distress, cognitive changes, and reduced workforce participation with increased healthcare utilization. The timing of this transition matters. Women experience these changes during what is often the most demanding time in their lives. Between the ages of 40 and 55, many are simultaneously contributing at the highest levels of the workforce, while at the same time caring for children, supporting aging parents, and serving as leaders in their communities. Yet access to care remains fragmented and inequitable. In Alberta alone, an estimated 300,000 women aged 35 to 55 do not have access to a primary care provider. Across Canada, women increasingly face long wait times, limited access to menopause expertise, and this has contributed to the rapid growth of private menopause clinics, effectively creating a 2-tiered system in which women with financial means can access specialized care and others cannot. The consequences extend far beyond individual women. Recent economic analysis estimates that closing the women's health gap could create a $37 billion opportunity for Canadians through improved workforce participation, productivity, and reduced healthcare costs. The good news is the solutions already exist. With support from the Alberta Health Primary Care Innovation Fund, we've developed a Cycles to Cessation clinic, one of Canada's first publicly funded, nurse practitioner-led virtual clinics specializing in the care of women in the reproductive transition. The model provides comprehensive assessment, evidence-based treatment, longitudinal follow-up, and evaluation of cardiovascular, metabolic, skeletal, mental, and reproductive health. Early implementation has demonstrated rapid uptake, high patient satisfaction, and significant unmet demand, and meaningful symptom improvement. Importantly, it demonstrates that accessible, publicly funded virtual primary care for midlife women is both feasible and scalable. My message to this committee is simple. Menopause is 1 day in a woman's life, defined as 12 months without a menstrual period. The reproductive transition is a decade or more. It represents one of the most important opportunities for prevention in women's health. For decades, women's biological realities during the reproductive aging have been minimized, misunderstood, or ignored. The ovaries are not simply reproductive organs. From puberty through menopausal transition, they serve as the architects of women's health, influencing virtually every major physiological system through the production of estrogen. If Canada is serious about strengthening workforce participation, improving population health, and reducing healthcare costs, we have to invest in evidence-based, publicly funded models of care that recognize the reproductive transition as a critical life stage in health rather than niche reproductive concern. Furthermore, when we provide women with the care they need during this critical transition, we can help them remain healthy, productive, and thriving while strengthening families, communities, workplaces, and the Canadian economy. Thank you so much.
Thank you very much. Now we'll go to Ms. Drapeau. The floor is yours for 5 minutes.
Thank you, Madam Chair and members of the committee. My name is Julie Drapeau, and I'm the Senior Vice President of Sales and Marketing at Purity Life Health Products. Purity Life is Canada's leading distributor of natural health products, supplying more than 30,000 products, over 1,000 brands, to more than 7,000 retail locations across the country. We employ hundreds of Canadians, including 181 women, and support retailers, healthcare brands, and consumers nationwide. I'm also a woman with lived experience of perimenopause who utilize conventional natural health products in private care. I'm here today both as a business leader responsible for supporting a large female workforce and as someone with lived experience. Women in perimenopause and menopause are often at the peak of their careers. They are leading teams, managing businesses, mentoring future leaders, and making significant contribution to Canada's economy. Yet, many are silently struggling with symptoms that affect sleeps, cognition, energy, confidence, and overall well-being. This is not simply a women's health issue. It is a workforce issue, a leadership issue, and an economic issue. When women leave workforce early, reduce their hours, or take a step back in leadership opportunity due to unmanaged symptoms, employers lose experienced talent, and Canada loses valuable economic contributions. I believe there is an opportunity for Canada to lead by improving awareness, providing workplace support, managing education, and access to evidence-based treatment and or natural solutions so that women can continue to thrive and contribute to their careers. I look forward today to your questions. Thank you.
Thank you very much. Ms. DeBow, now you have the floor for 5 minutes.
Good afternoon, Chair, and members of the committee. My name is Amy DeBow, and I'm the founder of Menovate, a Canadian company that guides corporations to be menopause inclusive through talks and through e-learning courses. Thank you for taking the time to make this undertaking of this important study. I spent more than 26 years in the corporate world. In all those years, I never once heard the word menopause. Not once. Then I experienced perimenopause. Women spend over 1/3 of their lives in this menopause transition, and most of us enter it without knowing what it is, what symptoms to expect, and where to seek help. I was no different. Hot flashes, heart palpitations, 2 frozen shoulders, sleep disruption, severe brain fog, all while trying to carry a heavy corporate job. I watched as other women silently step back from leadership opportunities, while others left the workforce entirely, not because they lacked any talent or ambition, but because the workplace was just not designed to support them. That realization changed my career trajectory. That's why I founded Menovate. Through my lived experience and my work with employers, I have heard from thousands of women across industries and levels of seniority. The challenges they describe are remarkably similar, and the support is just not there. Research shows that 10% of women are leaving their job because of menopause symptoms. Think about what that means. Experienced employees leaving the peak of their career, like I did, taking decades of knowledge with them and leadership with them. This is not only a health issue. It's a workforce issue, a productivity issue, a financial security issue, and an economic issue. In recent years, more women are talking about menopause. More healthcare professionals are developing expertise, and media coverage has grown. But the efforts remain in the infancy, and Canadian workplaces have not kept up. Managers are rarely trained on how to respond, and most organizations have never had the conversation. And while awareness is growing at the employee level, most executive teams still do not recognize menopause as a workplace issue. I would like to leave this committee with 4 recommendations. First, I recommend establishing minimum workplace standards for menopause awareness and education. Like other workforce harassment prevention programs, organizations must be expected to provide menopause training in employees for managers, leaders, and for their employees. This should include topics like relevant symptoms, coping skills, and how do you have a conversation with your employer. This cannot be just a one-session checkbox. The stigma around menopause has been built over decades. Meaningful change is going to take time. That also means bringing men into the room. Inclusion builds culture where women feel safe enough to ask what they need, get supportive responses, and feel healthy enough to stay. Second, every organization should have a formal menopause policy, so support is consistent rather than manager dependent. This could include flexible work options, temperature control, and break flexibility. Third, meaningful access to care. Menopause care should become a routine component of primary care, reducing the need for women to navigate multitude providers before they receive an evidence-based treatment. I saw a multitude of doctors over many years before I received an accurate diagnosis. I had the luxury of seeing both OHIP-covered and private doctors. Many women cannot afford this. I have enormous respect for the private clinics doing the work, but they are filling a gap that should not exist, and it is not equitable. My final recommendation is dedicated Canadian research, data collection, and national public awareness campaigns similar to the initiatives in Australia. Canada does not consistently measure the labour force impact of menopause, and we need national data. By supporting women through menopause, we can help experienced employees remain healthy, productive, and fully engaged in their career. Now that I received the treatment I needed, I feel strong, empowered, and energized every day to contribute. Every woman should be able to feel this way as they transition through menopause. Canada has the opportunity to be a leader in this space. Menopause is inevitable, suffering is not, and women leaving workforce shouldn't have to be. The great news is that menopause is a solvable workforce challenge facing Canadian employers. Education, manager training, workplace flexibility, and access to care can have a meaningful difference. Thank you, and I look forward to your questions.
Excellent. Thank you all. And now we're going to begin our first round of questions with Ms. Goodridge for 6 minutes.
Thank you, and thank you to all the witnesses for being here. This is such an incredibly important topic that is definitely not quite studied as much as it should be. And we heard about that very clearly in the last panel. I'm going to start with you, Dr. Norris, as you're a fellow Albertan, and wondering if you can describe some of the spectacular work that you guys are doing at the University of Alberta when it comes to this.
Thank you very much. I was fortunate enough to get what we call the Kaversen Chair in Women's Health Research, and definitely got into the literature. I had always done women's cardiovascular health and couldn't figure out why we were missing women's cardiovascular health. The symptoms are different, and had been advocating. And it wasn't until I got into the perimenopause literature. One of the things I think it's really important for the committee to understand is that we keep referring to it as menopause and educating women about menopause in the workday. As I said, menopause is one day of your life, and I think we need to do that paradigm shift. And our research has identified it to make sure women are aware of what's going on in their bodies and why they need to follow through. And I think if we frame it as same as puberty, we know the changes that occur until a girl gets her period, and then what goes on after that. Well, we need to know that as far as perimenopause and menopause is concerned. But one of the things we've created, or we are in the process of creating, is a digital program for women that they can go on to called AURA. It's Awareness and Understanding of Reproductive Health. And we've only been able to do this work because of the foundation that has supported us, because I can't get research dollars to do it. But it is.
And I'm just I want to clarify that. The Government of Canada has tons of money that they spend on research dollars, and you're not able to get research dollars from the Government of Canada to do this incredibly important work?
It goes to the committees and the Canadian Institute of Health Research Committees, and they just don't see it as a priority issue. We've only advanced, and we've been so fortunate to advance because of the Alberta Foundation for Women's Research in Edmonton. That's part of the collective that was talked about. But the awareness is such a key piece. So we've created this digital format that women could absolutely all get on and learn. It's about awareness and understanding. That's the key to this, because even with the workforce policies in place, if women don't understand what's going in their body, they're going to, 3 colleagues in Calgary ended up, young women that were very productive ended up getting MRIs because they could afford it, because they thought they were losing their mind, or they had early dementia, and it was the brain fog of perimenopause. So until you've experienced it, as we were talking, you can't understand it. And but women need to know to anticipate it, that this is what's happening.
And so I'm really curious, you talked about how you have a virtual clinic that's available in Alberta. I know in our home province of Alberta, we're incredibly lucky to have a spectacular female health minister in Adriana LaGrange, who is really putting women's health out there. We're the first province to move to 40 self-referral for mammogram screening. And so I was just wondering if you can describe what that virtual clinic looks like. So if a woman in Alberta was going through this stage of their life, how they could access it.
It's called Cycles to Cessation, and if they go on cyclestocessation.ca, they will be able to access the virtual clinic. It provides, the biggest issue is it's through primary care, and it provides a 50-minute initial assessment, because in primary care in Alberta right now, you get 10 minutes for your visit, and it just isn't enough to understand what's going on in your body. So it provides that, and then you're given follow-up care. And we look at every aspect of the woman's life and what's happening in their metabolic health, and their cardiovascular health, and their brain health. It might be hormones that they end up getting prescribed, but it may be other things that have to be addressed. And we were fortunate enough to get a 3-year grant to test the model, and we had a soft opening in February of this year. And as I said, it's a virtual clinic, and so you go online and you book your appointment based on criteria. But the most interesting thing about it is, I said soft launch. We've seen over 600 women since our soft launch. We're funded for 1 nurse practitioner, and we divided that into 2 NPs, so one could cover the other, and so 2.5 NPs, and that's what it costs for this clinic to be set up.
Wow, that's...
And it's scalable across Canada, because NPs are prepared to do this and ready, willing, and able. And right now they're all doing it privately, and we need to move them. This is public health for women in Canada.
Well, and I think it's so incredibly important, and I think one of the big challenges that we see in women's health in general is that it's understudied, it's underfunded, it's not understood, and we're supposed to just go and just deal with this. And so I think bringing attention to this is so important, because perhaps if you understand what's going on with you, you don't have to take the time off work, because you have the ability to find ways to manage those symptoms, or to know that you're just not going crazy and find different mitigation systems. Ms. DeBow, you're definitely shaking your head. Do you have anything to add?
Yeah, I mean, I suffered all of what you just talked about. So I would be, I held an executive role and be in front of meetings on projects that I knew lived, breathed, And I could remember nothing when I would go up to present. And it was horrifying. I did believe I had dementia. I had all the tests for it because when I would go to a doctor, nobody said that it was perimenopause for years. I did have the MRIs. I had all of the tests, and nobody put the messages, all of those pieces together. I personally did it myself. And I had to go back.
Sorry. That's the end of the time, but if you have additional comments, of course, you can send the written comments to the clerk. Now we're going to move to Ms. Wen for 6 minutes.
Thank you so much to the witnesses for being here today. This is such an important study, and my colleague just noted how misunderstood or lack of research we have in the women's health space. And I know it's going back some time ago, but the Women's Health Centers of Excellence program that was a Liberal Red promise back in '93 and then established the Centers of Excellence. Like, we actually have a foundation of doing really important work. It was on pause for some years and has come back now through the Women's Health Research Initiative, $20 million over 5 years. So the work continues, and we need more of it to make sure that we understand the implications for women's health. And I think about the evolution to actually talking about periods at the workplace. We now have to have this conversation about menopause because women continue to be in the workplace. So I want to thank all of you for the work that you're doing to try and address these pieces. Ms. Norris, can you talk a little bit more about the idea of NPs leading these models? We heard about one that was happening on the first panel as well, but where you think there might be some gains and whether or not there are provinces who are interested in using NPs and funding them publicly in order to meet the demands.
There have been changes in the Canada Health Act to make way for NPs to be funded, because if it's care that is offered publicly, then you can't privately charge for that. And that's going to affect menopause care in Canada, or perimenopause care in Canada, because the clinics are everywhere. We probably have 15 of them, the private clinics in Edmonton alone. The issue is you have to pay, and we are not getting close to getting the population that we're trying to reach as far as this care is concerned. I think of all of the women that are in the economy of the service economy that are going through with these symptoms and have no chance of getting any kind of treatment or care that they deserve. So the NPs can provide that care. It's a salary. It's not a fee-for-service model. It's a really economically feasible, simple model. We've set up the online format, and it's secure, and I just think it's the answer.
Thank you very much, Dr. Norris. Ms. Debeau and Madame Drapeau, both of you have experience on the HR side and the workplace piece. And I wondered, Ms. Drapeau, if you could talk about some of the best practices you're using in your own company, and Ms. Debeau, some of the leading sectors or industries that are actually thinking about this and coming at this in a way that we should be thinking about.
So on our side, we've been, I would say, very active in the past year because of what I've been through. And the fact that I faced a time where I had to play my role because I could not recognize myself anymore. And that opened up that discussion with our HR group in starting a group called Level Up at our company and investing in professional to come and educate women and men that we invite to participate, to educate them on what it is, what's going to happen. And also it was pretty good to have men's there because they could understand not only for the employees around them, but also for their wives at home. So we implemented that because that piece of education, we've talked about that a lot, is huge. It's important for women themselves to understand what's going on because they don't have that education out there. You have to go private most of the time, which I had to do myself. And I wanted our employees to benefit from that because we are building these leaders to replace us someday. And, we have 30 years old people coming in and we want to give them the tools. So when they get to that stage, they're solid. They know what's going on. So we've implemented that. We also pay for private access to the senior level in our company. to again give them those tools. And in addition to that, we also provide a service called Maple, where they have access to a doctor online. But again, the key piece here is the education, because you can get access to a doctor, but if they're not understanding or supporting, that's where we're kind of stuck here. And that's why, I'm here today to really stretch that with you. So thank you.
Could you add very quickly? I know we don't have a lot of time.
I agree that it's education, but it really starts in corporations by talking about it and calling out what is actually happening. Most times when I show up in a company, it is the first time the word menopause is being uttered in a company. And so just breaking the silence helps break the stigma by talking about it. So there's many things that companies, the best-in-class companies are doing. They've got chat groups set up internally. They've got accommodations that are formalized, putting policies in place, reviewing their benefits to see what benefits actually exist to cover women in menopause. Most of the time, a lot of them are there. They're just not linked to the fact that they support menopause. So there are so many things that can be done, but honestly, it's about bringing in educators like myself and utilizing, I have these e-learning tools that allow different people in the company to actually get, I agree very much, educated and then start talking about it, and especially having a senior leader stand up and be an advocate, willing to say, I have had it or I've gone through it, so that it's okay for the average employee to then feel comfortable to have that conversation with their boss.
Excellent. And now, Madame Larouche, vous avez la parole pour 6 minutes.
Ms. Larouche, you now have 6 minutes. Thank you so much. Thank you, Ms. Drapeau, Ms. Norris, and Ms. DeBeau for your testimony today. Dr. Norris, I'm taking notes, and we will certainly make recommendations based on what you're telling us here. Let me begin speaking about economic matters. Of concern, though, this was mentioned by prior panelists. Women, for a number of reasons, must stop working. They have difficulty staying on point in competition with men, and therefore they cannot retire with the same amount of money as a man will. Sometimes they have to deal with a postpartum depression, must stay on maternity leave longer, or women who have to stop their career, even temporarily, midlife, because they're in pain due to the menopause and so on. So now we have women leaving positions that they've worked in and worked for their whole lives. And there are prejudices, of course, discrimination. We don't necessarily reach the same levels of career as others simply because there's this age discrimination. Now, this has a real effect on women's economic position by the time they retire. So could you tell us a little more about the economic effect of all this on women? Ms. DeBeau, perhaps to begin with. Ms. Drapeau could follow. Ms. Norris.
Economics. One, of course, women leaving, quitting. They also are taking time off work, or they're stepping down. They'll take part-time. So 100% there is economic impact to the female and their future. That's what I talked about, like their financial long-term viability, right? But there is also a second side to it, and that is the corporations. So Amy Flood did talk about it a little bit before. So women are they're leaving their job. So think about when a woman leaves her job, it has to be then posted, it has to be backfilled, they have to pay to replace them, their teams are disrupted. So there is a huge cost when a woman leaves and has to be replaced. Second, many women going through perimenopause, like myself in menopause, take sick leave. I took multitudes of sick leaves because of it. So that cost as well. And then there's also productivity impact. So if companies would be willing to support women and get them access, as we just heard, that some companies are willing to pay so women can get the care, it's actually so much cheaper. They're going to pay to support their woman to get the care, and they actually then have this amazingly productive woman who's not taking sick leave and not leaving their career in the midst and the height of their contribution. So it is a very double-edged sword, menopause.
Yeah, I think to bring up some...
L'ajouter, plus particulièrement sur le fait qu'après, on n'arrête pas.
Allow me to add that we often hear that elderly women are often in precarious economic situations.
Definitely in our workforce. And I think that in the previous panel, we mentioned some big numbers, but just to state them, bringing them back here, the Menopause Foundation of Canada estimate that menopause costs the Canadian economy approximately $3.5 billion annually, which includes $237 million in employer productivity loss. So to answer your question on the women's sides, and if they can't continue, with the level of revenue they had when they get into retirement or anything, like they're dependent on the system. And again, they're still in need of care and they can't get that care. So it's kind of that, rolling of, always going on the government support, where if it was helped right out the gate, they would not only, rely on the government, but they will be flourishing and helping the younger generation, to grow and continue in their leadership, replacing them. So, that's where we see for us.
Respond, because one of the groundbreaking things I found out when I was doing the literature looking through the literature on this, trying to understand it myself, is the fact that this age, when perimenopause, your eggs start decreasing, follicles start decreasing in your late 30s, and that's when the estrogens actually start changing, and you'll have spikes and peaks and valleys, and it's these spikes and valleys that cause all of these symptoms. But one other thing that I read about that just blew me away was it is, as we said, the most stressful time of a woman's life. They're managing everything at the same time. And your brain prioritizes the production of cortisol over estrogen. So at the same time that your levels are doing crazy things, you're also producing lots of cortisol, which is meaning that you're under stress, which everyone is in this world. And so it's understanding that. The women need to understand that. And part of our treatments are figuring out how to turn off your sympathetic system so you're not under stress all the time. And there's really good methods to do that, and there's evidence behind it, but women just don't even know about it.
Thank you so much. Unfortunately, that's the end of our time for today. I apologize to the witnesses for the delay because of votes. But if you do have something else that you want to add, please send the written response to the clerk. Madame LaRouche?
Well, we're 24 past the hour, and we were going to work until past. Perhaps we could slip in a last question each.
Address here. And so you may have seen the circulation of the budget. The budget that was, we added a day to the shelter study, and so the estimate for the budget for 2000 was sent around. Do I have the support of the committee to approve that budget? Madame LaRouche? Yes, everybody's good. All right, so that's approved. And then at this point, I think that's everything, isn't it? Good. So I know people have planes to catch, but thank you again to the witnesses, and I will now adjourn.